So our physicians are with us tonight, and our panel is going to be joining us in just a minute. I hope everybody had a chance to go out and check out the vendors. And I wanted to remind everybody as you leave tonight that there's a bag with a goodie bag with some lots of nice things in it for everyone to take with them. And we do have winners for the 2 door prizes, and we'll give that away right at the end. And we're waiting just a minute to get the rest of our physicians with us, and then they're going to be joining us. On behalf of the board of directors, the hospital employees, the staff that work at the hospital, all of our partner organizations, the physicians, we wanted to welcome everyone tonight. We know that both breast cancer and ovarian cancer are women's issues, right? And they're issues that we as women have had to deal with, and that we have a lot of great partners here tonight that are going to help give us more information about all the services that we have and what they can do to help us. At the hospital, we have a new 3D mammography, and it's really exciting and interesting to have that tomosynthesis here in Oswego. As someone described it to me, it's, and we'll let Dr. Wang talk about this a little further, but they said that it now gives you, where you used to get a picture, a book, the picture looked like a book with the front and the back. Now they can see everything inside. So it's like being able to see the whole book. So it's really interesting, and I can say that I had one. It's a little bit quicker, and it was really marvelous, and it was very interesting to see everything inside it too. So I think our panel's all here, and they can come up and join us. Or you don't have to hang in the back. Come on up and take your seats. I'll come and get the cards from you in just a second. You can sit with your name tags, or you can like mess everyone up and sit with different name tags. So welcome and thank you for coming, and we're going to let everybody introduce themselves, and then we'll take some questions.
Hi, I'm Alex Banashkevich. I'm a radiation oncologist.
Sam Benjamin, the medical oncologist.
Hi, I'm Lisa Lai. I'm a breast surgeon.
Hi, I'm Raj Mahajan. I'm an OBGYN.
Hi, my name is Jay Singh, and I'm a general and breast surgeon.
And David Wong, I'm a breast radiologist.
So one of the first questions that we received early on was, what are the causes of ovarian cancer? Who would like to take that one? That's a Dr. Mahajan.
Okay.
Oh boy, here you go. You think you got that?
What are the causes of ovarian cancer? Well, there are a lot of different things which cause ovarian cancer. A lot of times we don't know. Certain environmental contaminants can cause ovarian cancer. A lot of people who get ovarian cancer have a family history.
So what kind of things can we do as women to prevent cancer, and what kind of screening should we be looking at doing?
Well, one of the big new things that's happened with ovarian cancer is we now think that a lot of ovarian cancer originates from the end of the fallopian tube. We used to think ovarian cancer started from the ovary, but now we think it starts from the fallopian tube. So why that's important is because when we do sterilizations or any abdominal surgery in women who still have a fallopian tube and don't want to have any more kids, we can take out the fallopian tube, and we think that dramatically reduces their chances of getting ovarian cancer. When we used to do tubal ligations, we would take out a little piece of the tube and leave the end part of the tube, which is where ovarian cancer starts. Now we think that we can take out the end of the tube and take out almost the whole tube and have that count as a sterilization, and at the same time also dramatically reduce the chance of getting ovarian cancer and still leave the ovary so the women can have hormones from the ovary. We also know that taking birth control pills dramatically reduces your chances of getting ovarian cancer. People who take birth control pills for 5 years cut down the risk of ovarian cancer by 50%. If you take them for 10 years, it cuts your risk by 90%. So that's very, very protective.
So what are some of the treatment options available for those unfortunate women that do end up with ovarian cancer?
Well, the problem with ovarian cancer and why it's bad is that we are not really good at picking it up early. When people start to think that they have ovarian cancer, the symptoms that they might get might be very vague. They talk about having bloating, having pelvic pain, having urgency, feeling like you might have to urinate all the time. These are very nonspecific. A lot of people, when they look back when people had ovarian cancer, may have had symptoms like this for a few years. But because they're so nonspecific, a lot of times they get blown off and people don't even go to a doctor. And so when a woman gets ovarian cancer, her chance of getting it is only 1.4%. One woman out of 70 will get ovarian cancer. So it's not very common, but it is very, very severe. To do screening for ovarian cancer, you can check CA-125, which is a blood test, and you can do pelvic ultrasounds. Pelvic exams can help a little bit, but it's hard to feel very subtle changes in the ovaries because they're very small. They don't recommend doing the ultrasounds and CA-125s in people who are low risk because they have very high false positive rates. CA-125 is not very specific for ovarian cancer, meaning a lot of other things can cause small elevations, which may end up leading you on a wild goose chase for somebody who doesn't have ovarian cancer. But for people who are at high risk, they may talk about screening even twice a year with ultrasounds and CA-125s.
Okay, thank you.
Thank you.
So we're going to jump over to breast cancer. And one of the questions is, what are some of the screening options for breast cancer? And I think we discussed to start with that we have some great mammography, and we're going to have Dr. Wang speak about that.
Well, the standard screening that's recommended is a mammogram, and now the 3D mammogram actually provides a much more detailed look at the breast. And it's not just good for dense breasts; it's good for all densities, but particularly helpful in dense breasts. So that's our mainstay for screening. In women who have dense breasts, we also recommend doing a breast ultrasound, which uses sound waves to penetrate the denser tissue and gives us one more way of looking through that tissue. Another way of screening, if you're at high risk, is the screening MRI breast exam, and that's actually the best test. But it's at this point it's pretty expensive and more involved. But it really is our best screening tool. So if you do qualify for that by all means, that's the best way of looking.
Dr. Singh, did you have more to add to that?
No, I think he pretty much included everything in there. The only thing is with the MRI, we have a MRI because MRI is so sensitive, it's highly sensitive, so it would find something which we would chase after, and it would be just false positive finding in the MRI, but ultimately it would just be a finding. So we have to be careful while doing the MRI. So we can't just do MRI in everyone, as Dr. Wang said, that the patients have to qualify for that. Let's say if someone has a lifetime risk of more than 20% because of strong family history, or if they have had some findings like lobular carcinoma in situ or atypical cells in previous biopsies, those are the patients that would have a high risk, lifetime risk of cancer, and those are the patients who should get MRI every year, alternating with mammogram every year. So it's like every 6 months you're doing a screening for those patients.
Okay.
I have a question.
Sure.
When you talked about dense breasts, does that go away, or do you have dense breasts forever?
So the question is, do you have a dense breast forever, or is it something that goes away?
Some people do, and I've seen dense breasts in very old patients. But most of the time, what happens is, as you age, fatty tissue replaces your glandular tissue, and so your breasts usually become less dense as you get older, but not for everyone. So.
Okay. Yes, ma'am.
The new machine you were talking about that you did, does that make it any easier?
Yeah, it does. It actually gives us basically it's like what the CAT scan did for a chest X-ray. This is the tomosynthesis does for mammogram. It allows us to now look at the breast in thin layers, and so that's particularly helpful in patients who have dense breasts, because oftentimes it was tough to see through that area. It would just be a complete whiteout. This allows us to kind of section through.
Do you find that there's more callbacks, or that you find, or maybe you can see more so you don't have to call back?
Actually, the literature shows that there's fewer callbacks because a lot of times you can see something that you had a question about, and now you can see it well enough that you don't need to make a callback. Oh, sorry.
The mic stopped working, if you can hear me.
Oh, mic is not working. Oh, okay. Oh, there we go. Okay, now it's on.
No, it's on.
All right.
Okay, thank you. So the question had been about the tomosynthesis. That's what he was answering. Yes?
I'm just wondering, when you schedule your mammogram, do you have to request a 3D mammogram, or are they all being done 3D?
Currently, right now at Oswego Health, we have one 3D at the hospital in Oswego. The other three campuses are not yet tomo, they're not yet 3D. We're moving towards that. So if you did want 3D, or if your doctor's suggesting that, then I would encourage you to say when you're scheduling that you'd like it at the hospital. Any other questions before we move on? Yes, ma'am.
I have a question. What are the factors that doctors look at that put you in the high risk for ovarian cancer, besides history?
Did you hear the question about ovarian cancer? Ovarian, sorry.
So probably family history is going to be your big risk factor. I mean, there aren't very many other people who have huge risk factors besides family history.
So that's kind of the only factor that's
That's going to be the big factor that we look at.
So one of the other questions was, what would be some of the high-risk factors for breast cancer?
There are things. Is this now? It should be working now. So there are more factors that are recognized for risk factors for breast cancer. And there are things that we do on our initial assessment and talk about as you come for follow-up visits, and also that your breast imaging center evaluates you for when you go. So you may have filled out forms asking about. This is just timing out. Yeah. Asking about what age you had your first menstrual period, what age you entered menopause, how many kids you've had, if you've breastfed, what age you were when your first child was born, if there's any family history of breast or ovarian cancer. Some fancier models also consider how dense your breasts are, because cancers develop in the actual dense breast tissue versus the fat. They're not so much originating in fat, but the dense tissue. So that can increase your risk. Also, number of biopsies you've had and whether any of them had atypia or abnormal cells. So all these can kind of be taken into account, plugged into calculators, and you can do it yourself or you can do it with your doctor. You can get real numbers to estimate what your likelihood of breast cancer may be. High risk for breast cancer is generally anyone whose calculation falls above 20% lifetime risk of breast cancer. That's when we start considering using MRI for screening in addition to mammogram, and we talk about using medications such as tamoxifen or other medications to lower that risk, and doing more frequent exams and things like that.
If you have breast cancer in one breast, what are the odds of you getting it in the other?
That's a great question. All the calculators that we can use aren't going to really apply once you've had breast cancer. Generally speaking, we think it's about 0.5% per year, maybe up to 1% per year of another breast cancer, but it's probably a little bit less than 1%.
So another question that was sent in was, if I'm diagnosed with breast cancer, what are my next steps and who should I see next? Back to you again.
Maybe you should see a breast surgeon next? That's a good question. So we really work as a team. So if you are diagnosed, you'll often be referred to a breast surgeon or to the breast cancer team at the cancer center to be seen.
So if you're diagnosed, you generally will go see your breast surgeon, and then or your team, And then there's some other options too, where we get into medical oncology and radiology.
So as much as possible, we try to approach each case in a multidisciplinary fashion. So, and like Dr. Lai said, we work as a team. So I would say majority of cases, the patients get referred to the surgeon, but there are indications where someone has a very locally advanced breast cancer where we would need to, as a medical oncologist, I need to get involved up front sooner rather than later to allow the tumor to respond to treatment before they can actually do optimal surgery. So, but we look at cases, from the three of us, as a surgeon, as a medical oncologist, a radiation oncologist, we come together, we review each case as much as we can and come up with the best treatment plan that's individualized to each patient. So,
Okay. One of the questions we had was, can I receive all of my services here in Oswego? And Oswego Health doesn't provide all the services themselves. We partner with several people that do, and one of them is radiation oncology.
Yeah, let's see if it works. It sounds like it does. Yeah, so the beauty is that we, as upstate, I'm upstate physician, but we do have an office in Oswego County. Benjamin is the upstate physician. His office is in the hospital. Died out? Okay. So the beauty of working as a team and also having access for people in the community to not just Oswego Health physicians, but to services, and including clinical trials that we can get our patients here in Oswego, because those clinical trials are available at upstate. So that's one of the beauties. The other beauty is that when we know each other and we work each other, and everybody here is very collegial, and that really helps our patients, I think. So what we're trying to do for our breast patients right now, actually before they make decision to go for surgery, they will see all three of us. And sometimes it is right, patient go for the surgery first, and then consideration for systemic treatment and radiotherapy after. But sometimes chemotherapy goes before surgery. So, but the beauty for the patient is she will know ahead of time what will be tentative plan of action and how many months or how many weeks will it take to complete the whole intended treatment.
So even when patients are not seen necessarily in a multidisciplinary space at the cancer center, and we see them individually here, all of us are on speed dial with each other, right? So we get to, we communicate in real time, and we know how we should, in a way, approach, because we've been working together for several years now. So we kind of get a sense of, Dr. Lai will know, when do I need to call Dr. Benjamin and talk about what we call neoadjuvant therapy, treatment before surgery, in these kind of situations, So I think it's a lot of it has to do with communication and interdisciplinary partnership. So, yeah.
Another question we have is, if I'm diagnosed with breast cancer, what are the next steps for my daughters, and what kind of screening should they do? And I think, Dr. Lai, you mentioned that on the screening form it will ask you some questions. But what is moms that we should pass along to our daughters?
I get this question all the time, actually. Once kind of the initial shock of the breast cancer diagnosis and my patient is settling down and treatment is started and we're kind of getting into like that cruise control of surveillance, then, daughters who come with them to visits, or maybe they're not, but now the patient can finally start thinking about other things. I get this question all the time. So, what do you tell your relatives, your sisters or your daughters? I think in an instance where it's clearly running in the family, that's an opportunity, or, several people in the family are having cancer, breast cancer, or others, then you might want to look at the genetic risk in the family. Should we be doing genetic testing to try to detect a gene that's causing this so that the other relatives can get checked before they ever have cancer, and then maybe we prevented something? Another thing too is when a patient has breast cancer at a young age, or they come because they're young but their mother had breast cancer at a young age, and think that's when we kind of change mindset a little bit because, we may not start ordinary screening until age 40, but if your mom had breast cancer at age 32, we're going to move all of that up and start screening you in your 30s also. So I think that's kind of where things change. And I think it's important for, the person wondering about their own risk to talk to their doctor so you can kind of do some of those calculations in the individual risk assessment and find out what is the right screening program for you.
Oftentimes we hear about something called preventative mastectomy. I know it's popular with some celebrities, and we've seen that in the media. Does anyone want to talk about that a little bit?
So the preventative mastectomy is basically, mastectomy is removal of so preventive mastectomy is basically you removing the breast to prevent the breast cancer. That's what it means now. But like for example, just because someone does have history of breast cancer, doesn't mean that that patient should have their other breast removed. As Dr. Lai said, that chances of cancer in the other breast is 0.5 to 1%, depending on whether it's hormone receptor positive or not. However, in cases like someone who is BRCA positive, does have a gene which is positive, in those patients, getting the breast removed does decrease the risk of cancer, lifetime risk of cancer by 90%. So that's what the preventative mastectomy is, and it is helpful, as Maggie also said. It is helpful when the patients do have those positive genes because it can prevent cancer in those patients.
In those same patients, they also are at increased risk for ovarian cancer in a lot of times. So that depending upon which surgeries we do, we talked about removing fallopian tubes. They also talked about preventively taking out ovaries for people either who have no increased risk, and you're going to do a hysterectomy or some other surgery, depending upon their age and risk factors. A lot of times we'll remove ovaries. For people who are BRCA carriers, generally we talked about removing their ovaries when they're done having kids as well, because they're at increased risk for getting breast cancer and colon cancer and ovarian cancer.
I have a question. Sure. Could you explain a little bit more about not just the BRCA genes, but because isn't there other genes that can affect your risk for breast cancer? So how do you determine what people get the test beyond the BRCA test? And you know what I mean? Are you understanding my question?
You mean like the pelvic-tooth, like to test positive for the pelvic-tooth gene?
How do you decide who gets the full panel or just the BRCA?
I think when we determine that patient it does require a genetic testing, it's not just the BRCA gene. The patients get the full package. They get the BRCA1, 2, P53, P10, and other genes as well. So so what we do, we have a genetic counselor as well. Her name is Gloria Morris. So we make the referral to her, and she does. Either we can do the blood sample or even the saliva, and those patients do get the genetic testing. So it's just not the BRCA, but all other genes are included.
Thank you. Yeah, the way I approach it is if there's a patient who clearly meets the criteria that we standardized criteria for genetic testing, a woman who has breast cancer, age 45 and below. Okay, so you don't have to worry about insurance not paying for their. So we can actually. I just had a patient today who's 38 and has breast cancer and has a relatively strong family history, and we need to make a timely decision whether she wants to have bilateral mastectomies if she is BRCA positive versus just getting a lumpectomy. And I spoke with Dr. Morris, and what we did was I was able to order one of those commercially available extensive panel kit for her that includes all the ones that we commonly look for: BRCA1, 2, PLB2, CHEK2 mutation. Most of the panels include most of the ones that, that would be, which have high frequency. What happens is if I do that, then a month later when the test results are available, there's enough time for that patient to meet with Dr. Morris, go over the results. And if Dr. Morris, while taking a very more detailed family and personal history, decides that there needs to be additional testing, she can add on those specific testing to that panel so that it's as comprehensive as possible. If someone comes to me and the patient has the family history and the personal history is not as definitive for testing, those are the patients that I will wait for them to see Dr. Morris as in genetic counseling, and then she can determine what needs to be done appropriately.
Question from the audience about inflammatory breast cancer, how to diagnose it, the prognosis, and what gene can they test for. So inflammatory breast cancer is unique. It wouldn't happen with all breast cancer, so it's not like if you just left cancer there, it would all turn into inflammatory breast cancer. There's something very unique about it. Oftentimes, there's a rapid change in the breast. The breast is enlarged, heavy, swollen. It has like an orange peel appearance because there's so much fluid in the skin. It's reddened and warm because tumor cells are kind of invading the skin and blocking the drainage of fluid from the skin. So it's a unique entity that happens with few patients, not often. Oftentimes, you may wonder what's really going on at first. Do I have an infection? Or is this inflammatory breast cancer? To diagnose it, you would kind of just start with the basics, seeing your doctor, having a mammogram, doing an ultrasound if you need it. If there's something there on the mammogram, like a mass, they'll offer a biopsy. If there's nothing there that's showing up as a lesion to be seen in the breast, then we'll do a little skin biopsy, which can help diagnose it. The treatment, because it's a fairly advanced breast cancer, the treatment is fairly aggressive. So we'll usually do chemotherapy first, try to shrink everything down, get the skin back to normal. Then, once there's been a good response, we'll do a mastectomy, remove the whole breast and the draining lymph nodes under the arm. Then, often, there will be the need for radiation after surgery, and sometimes more medicines like hormone blocking pills if it's estrogen sensitive. There's no real gene that we can test for, so we would use the same guidelines that we use now to look at family and personal history to decide if genetic testing is needed just in general. And as far as the prognosis, I think that's a question that's always so hard for us to answer. I think it really depends on some of the other features about the tumor, like whether it's estrogen sensitive or HER2 sensitive, or whether it had a really good response to the chemotherapy or a partial response. So there's no real one size fits all for that, and even if we thought we knew, there's always exceptions. So I think it would be really hard to give, an exact prognosis.
Can I say something?
Yeah.
My daughter-in-law died of inflammatory breast cancer. She had breast pain in about July. This is 8 years ago. Just some pain in her breast. She went to Hershey Medical Center because they lived in Harrisburg, Pennsylvania. She went to Hershey. She had a mammogram. It showed nothing, absolutely nothing. So that was July, August, September. By October, she was watching a segment on Good Morning America, and it was on inflammatory breast cancer. And she said, "Oh my God, that's me." She went right back, and the next day, they did a biopsy, and she had all her records, and she was on her way to Johns Hopkins at that point, because apparently a mammogram doesn't show it. It's in the skin, apparently. And by the time, they even said down there that had she known even 2 months earlier that this is what they would have been dealing with, because it's so aggressive once it's there. And they only gave her 30% chance at that point of being alive in 5 years, and she died within 5 years. But her treatment consisted originally of she first had to have the radiation and whatever, because they said since it was in the skin, they couldn't operate on her because they needed to kill it in the skin. Then she had the breast removed. And she went through 1 year, I think, of being pretty good, but was all through those treatments, and in the end, really, her bone marrow was gone, or whatever, it just, everything was, but that was a difficult thing all she had was pain to begin with.
We have another question here that I wanted to be respectful about. And the question was, is thermal imaging reliable test for breast cancer, especially someone with dense breasts?
Yeah, there was a lot of hope early on that would be a simple test, not requiring any compression. But as it turns out, it's not sensitive enough to pick up tumors at an early stage. It can definitely see large tumors, but hopefully at the point that you would pick it up on thermal imaging, you would have picked it up much earlier by more conventional techniques. So currently it doesn't really play any role in breast cancer screening or diagnosis.
The next question, and then we'll get right to you after that. The next question was, I'll read the question. When the cancer team of 2 daughters with breast cancer recommended breast MRIs for the mother, so 2 daughters had been diagnosed with breast cancer, and the team recommended an MRI for the mother with dense tissue, but the insurance company denied it. What would be the best second screening?
Well, the standard screening of mammogram and ultrasound would be what you should be pursuing. But the MRI really is the better test, and so I think there should be some means of justifying getting that test. It might just be answering the right questions on a questionnaire.
Yes.
That was my question, and excuse me, they did cover it for 3 years, and then it's been denied for about 4 to 5 years. My doctor tried 3 times, and it was denied, and I called the insurance company each time, and they said, well, they hadn't had any indication of any need for it because nothing had showed up previously, which is rather a foolish answer, I think. But when you said that you're saying it should be pursued, is that what you're saying?
Well, yeah, I wouldn't not do the mammogram and the ultrasound, but really those are not a substitute for the MRI, especially if you have dense breast. So I'm not sure where to go from there.
I get that question sometimes from patients where, I think we look at risk where, if your elder generations had cancer and you're the younger one in the family, then you're at a certain risk. But when you reverse it so that you're the mother of daughters with breast cancer and you put it into the calculator, I think your risk will be more favorable than theirs. The fact that
You mean more favorable, meaning that it's less?
better, less. So I think, that's where you and your doctor could plug in the numbers, and maybe you'd be surprised that it would be a little bit better than you think. It works kind of a little bit differently as you go to the generation above because you've lived this long without breast cancer.
When you say plug in the numbers, what do you mean?
Like some of the calculators that can be used, like when you go to your breast imaging center and they have you fill out information about your personal history, your biopsy history, your family history, or when you're with your doctor and you're talking about what is your risk of having breast cancer,
It might be better than you think. I'm not sure, but,
Just one more
yeah.
thing. When you mentioned the thermal imaging, that it was less accurate, that was recommended for me. Is it later findings now that it is not a good diagnosis?
No, it's been studied. Actually, it's really fallen out of favor a number of years ago. Probably about 10 or 15 years ago, I think, is the last time that I think any serious study, looked at it, and again found that the other tests had become so much better in the meantime that there really wasn't a role for thermography.
So another question was, are there support groups locally for survivors of breast cancer? There is. There are several, and I think they're represented here this evening, and I think someone's going to tell us about it. You don't want to tell us about it? There you go.
Hi, my name is Kathy Otterkirk. I am the president of the Care and Share Breast Cancer Support Group of Oswego County. We've been going strong for, I believe, about 20 plus years. And we meet at the Fulton Medical Center upstairs in the medical center. And I have some of the ladies here. I have Caroline, Beverly, there's Sue Burns and Pat Okoneski that are there as well. And we help ladies go through the motions and the other things that come with the breast cancer. So there are groups out there. If you're interested, you can see me. I can give you more information.
Thank you. That was wonderful. Another question that comes up is, what can we as women do to prevent breast cancer? Are there healthy lifestyles? Are there things that we should be doing that would help prevent breast cancer?
So healthy lifestyle is obviously, what studies have shown that someone who has high BMI, they are at higher risk of having breast cancer. So yes, the exercise is always good. No drinking too much alcohol is also helpful, and the breastfeeding is also the studies have shown that the breastfeeding also helps in reducing the risk of breast cancer.
And of course, isn't one of always the best ways to work on that is to make sure that we get our regular mammograms and have a regular breast exam?
Yes, I think, what are the exact numbers? Mammograms decrease your risk of dying from breast cancer by 30 to 50%. So I think that's considerable. And, with the new technology that we have, especially using the 3D mammogram with or without the ultrasound, if you qualify for that, if you're doing that regularly and just keeping up with your own self-exams and clinical exams, odds are if you develop something, it should be detected when it's really, really small.
Yes.
I have a question
Sure,
about
Pat.
radiation exposure. First of all, whether the 3D mammo is better or worse in terms of the exposure. I'm thinking maybe better because there's a possibility you don't need to repeat any part of the x-rays. And the other question, I heard a show one time that was talking about a thyroid collar for mammograms, and unless you ask for it, you don't get it. Is that a necessary thing? You're grinning.
Do you want to answer that one, Dave? So we're going to have Dave from Medical Imaging come up and talk to us, or Arlene and Dave, because Arlene is actually one of the technicians that works with this. So I think that she would be happy to answer it. We're going to put her right on the spot about the thyroid collar because it's quite the discussion.
They're readily available at all sites. You do have to ask for them. It does. There are certain patients that necessarily can't wear them. It has to do with your body habitus. If you're kyphotic, and the collar might get in the way, but there's very little radiation to the thyroid, so it's really not very necessary. But we do have it available if you do want it.
You
You want to talk about the dose?
Yeah. So the amount of radiation you get from a tomosynthesis or a 3D mammogram is the same as a conventional mammogram. We're just using the technology to get much more information out of it. And also with the newer machines, in the past it used to be that the X-ray beam was kind of more of a wide spotlight. And the X-ray beams in the newer machines are very highly collimated. So the radiation really is going all to the spot where where you need it, and there's very little scatter. So in the past, it was probably more important, especially like if you were getting dental X-rays too, to have your thyroid shielded. But these days, it can hurt, but it's not really as critical as it used to be.
Do we have other questions for our panelists? Yes, ma'am.
Is there a cutoff in age for having mammograms? Because I've heard some people say after a certain age, every 2 years, or how long do you keep having them?
85?
It's hard because the different societies give different recommendations. So if you're someone who's had breast cancer and you're in good health, you should continue with your mammograms yearly, probably regardless of your age. If you want to start considering tapering off in your high 80s, 90s, fine. But, generally speaking, the purpose of mammogram is a screening test. So if you have good health and you're expected to live for the next 10 years, then you should have it. Sometimes they talk about when you're, I think, around age 74, you can go to every other year. Is that right? But in practice, I think, at least the patients who are coming to us, they either have personal history or biopsy histories and a reason to be coming to us. And if they're in good health, we will generally continue on yearly, unless, of course, there's personal preference.
And I think the problem is it's a shift. The goalposts have been shifting because women are living longer and healthier, and so and so now it's not that uncommon for us to see an 85-year-old who stopped screening at 74 and now has a breast tumor, big breast tumor. So I think this will need to be looked at more and more epidemiologically and in terms of screening guidelines. And so I completely agree with Dr. Lai's statement that if you are healthy and you're expected to, if you have a mother who lived to her 98th or 99th birthday, you probably should be getting your mammograms, unless you yourself have a lot of other comorbidities, right?
Now, I know sometimes there's women that put off having a mammogram because they don't feel they can get in or there isn't it's not convenient time for them. But we are open in Oswego, a little commercial for Oswego. We are open extended hours, and so we do that. And also, we have a lot of partners in Oswego County. And can I call on you to speak about what we can do for people who maybe don't have enough funds to cover their mammogram? Sure. Luckily,
Absolutely.
I heard you speak about that earlier.
So I'm Carolyn with the Cancer Services Program, and we offer free cancer screenings for anyone that's uninsured, age 40 to 64, for breast, cervical, and colon cancer. We work with a lot of partners throughout Oswego County, now Lewis, Jefferson, and St. Lawrence County as well. And we also extend hours. So we have an upcoming event even on Saturday. So we have additional services just to give that opportunity to women to take care of themselves, because all too often we don't take time out for ourselves, and we have to do that. So we're around to take care of the people that we love. So,
That's important. Oh, you want to talk about the pink ribbon?
The pink ribbon? So we do have a table out there if you'd like to visit us. On October 27th, we are doing a human pink ribbon as well to honor all of our survivors and all of our fighters. And remember the ones that we did lose. That will be at our Pulaski Health Center. And that's a women's health event. So there will be free screenings taking place there in conjunction with Connects Care and Oswego Health. So there's flyers on my table. We'd love for you to get your pink on and join us that day, again, Saturday, October 27th.
Thanks. Sure. Do we have other questions for our panel? Yes, ma'am.
I have a question for Dr. Lisa. I have a friend that just had a lumpectomy, and the doctor has told her about a new thing, Biosorb. And I just wonder if you've heard about it or not. It's not around here.
Okay. All right. Biosorb. It's a piece of plastic with some metal on it, and it can be placed in your lumpectomy cavity at the time of surgery to help identify the lumpectomy cavity for the radiation oncologist to plan your radiation. And I've seen it. It comes in multiple sizes. I've had the reps hunt me down for it, but it costs $1,000. And I just can't justify that cost to use it in my practice because that's really, really expensive. So the way that we currently will mark our lumpectomy sites are by putting a couple clips in there to mark it for the radiation doctors, and and I think that gives you a good target for planning treatment.
Yeah, it helps, but even without a clip,
You can find
I
it.
can do it.
Yeah, yeah.
Oh, even without
so,
But clips are helpful. And again, the idea is, if I'm not sure, the beauty that I can always call Dr. Lai and ask her what exactly happened during the operation. I have access to and also access.
So the only reason you're not really saying too much is because of the cost of it?
well, it's really expensive, but I don't know if there's a big therapeutic benefit in putting that in. I think currently we have a good way of labeling the cavity. The other thing too, the company will tell you is that it helps the tissue grow back into that spot because they've had a few patients that then had surgery and had it removed, and they examined the cavity and they could see that the tissue had filled in. But I think, when we do the surgery, we're always sewing that tissue back together anyways. I really think, in my personal opinion, it's a little bit overpriced, and it doesn't have a good therapeutic benefit to the patient.
So this has to be done when she has a lumpectomy?
Yeah.
Okay.
Yeah, you put it in at the time of surgery, the Biosorb. Yeah, I can't think of any other use for it, so I'm not sure. Is your friend having another surgery?
No, she's going to have it.
Oh, going to have it. Okay, and they're going to put a Biosorb. Okay. Yeah. Yeah.
She didn't mention how price-wise or anything about that.
Yeah.
Insurance, do you know if insurance covers it?
I truly don't know.
Well,
yeah.
every insurance would be different, and even in different markets or different areas of the country, different insurance, even Medicare makes different decisions depending on what part of the country you're in when that occurs. Other questions? I think there was another question or two. Can I go one back and then I'll come forward?
I know that there's no screening for ovarian cancer, but do you guys know anything anything on the horizon? Any research? Is there anything coming?
Well, they've been looking at a lot of different tumor markers that might help, that are better than CA-125. Every couple of years they come out with a new one. I haven't seen anything that's supposed to be that much better, but they keep looking. So hopefully someday.
Okay. We have another question right here, and then I'll get right back to you.
Often ultrasound is used when women have dense breasts. Is that a good option for women with dense breasts rather than a plain mammogram? And if so, what do you do if your doctor orders the ultrasound and you have dense breast and your insurance company won't pay for that?
Yeah, so an ultrasound is a good option when somebody has dense breast because it gives a different way of looking into that tissue, and so yeah, you're able to see different things. But if generally, I think most of the time the insurance companies now should be covering a breast ultrasound if you have dense breasts.
I think if you have trouble with your insurance companies covering things that are needed that your physician is recommending, then you have the right to appeal it, and that information should be there. It's buried in the insurance policy, and it's buried there, but there is a way to appeal it by getting the medical records, getting supporting documentation, and then working with your insurance company. And I know tests are expensive, but we also need to remember that the insurance company is paying for the test. They're not dictating whether we can get it or not. We still have the right to get the test. We just then have to come up with the money to pay for it.
Isn't an ultrasound cheaper than a mammogram? Actually, it is.
Actually, generally, it is.
It's not in addition. It's not it's addition. You do a mammogram, you see the dense breast, and then you do an ultrasound. It's not instead of a mammogram, so it's on top of it.
So that's very important that the mammogram always comes first, and it is very diagnostically sound.
Then just going on with that, the mammogram would determine whether an ultrasound is needed, or you get the ultrasound anyway with a dense breast.
Yeah. So on the mammogram, if we see something that looks suspicious, then we'll recommend an ultrasound, whether or not you have dense breast. But most of the time for the ultrasound screening, it's on mammogram, you see that there is dense breast tissue, but you're not seeing anything suspicious. But you're not seeing everything that you want to see. So that's when the screening ultrasound is recommended. It's when you have the mammogram, you see that it's dense tissue and want to be able to see further. So that's when the ultrasound.
Should be done with a dense breast.
Correct. Yeah.
I think it's worth it to ask your doctor when you get a mammogram and they tell you it's normal. Ask them if your breasts are dense or not, because I certainly see some people who come from some places who have dense breasts on their mammograms, and for whatever reason, the person who ordered it didn't follow up.
I've never been recommended.
Well, it depends upon who's.
Right.
Radiologists make a recommendation, but the doctor who orders the test
So
can either follow it or not.
Right, and when you have a mammogram at Oswego Health, you will get a copy of the results in the mail, and it will say on it what your score is and whether or not you were considered to have a dense breast, and that's right there on it. And if you've had one in the past and you don't have that information, you're not due for one again, you can, through our medical records department, go on the portal or ask for a copy of your most recent mammogram and then take that to your provider, because your healthcare provider would be the one who could best help you understand that information and review your other risk factors that you have going on to make decisions on treatment. And here I'm speaking. Am I on the right track? Okay. Other questions? One more. Okay. No, that's okay.
I wanted to follow up with hers. That was excellent. Very good. Before, and at the beginning, someone I think here mentioned blood work tests that can determine some cancers, and what are they? And is that something that is done, like you get your cholesterol checked every 6 months and whatever?
It was a CA-125 for ovarian cancer. The problem with that is it's not a very specific test. In general, they don't recommend doing CA-125 for people who don't have a high risk of getting ovarian cancer, for people who don't have symptoms, for people who don't have a worrisome mass on ultrasound, because you're going to end up getting a lot of borderline things that it's not positive or negative. I mean, it is, but there's a range. And so things that look really bad usually have a really high CA-125. You already know that if someone has something that looks really bad on an ultrasound. Really where its benefit is if someone doesn't have that or things look relatively normal. But you have a high false positive rate. Insurance companies generally don't cover for you to do a CA-125 without an increased risk, without having other symptoms or an abnormal ultrasound. So for people who do have a family history, for people who have a history of breast cancer or other syndromes that may increase the risk of getting ovarian cancer, certainly doing CA-125s are things that we do all the time. For people who don't have those risks, we still do them once in a while at their request. A lot of times we have to fight really hard with insurance companies to get them to pay for it, and a lot of times they ultimately don't pay for it.
Just want to chime in because a lot of my patients ask who are breast cancer survivors or completed their most of their treatment about the utility of the tumor markers for in detecting early recurrence for breast cancer. And we've known for some time that because of the high false positives that we have stopped doing routine tumor markers for breast cancer patients. The only time I routinely do tumor markers is when I know that the patient has had a recurrence, biopsy proven or on imaging, and then I'm using those the elevated tumor markers to gauge response to the treatment that I'm using in the stage 4 metastatic setting. But otherwise, routinely, we shouldn't be doing tumor markers as a means of looking for recurrence because of the high false positives.
Yes, ma'am.
One more thought
Pat?
on that. The transvaginal ultrasound, why wouldn't we be doing that in women as they get older, looking for ovarian, like a pap smear? Is it the cost?
It's the cost. It's the cost. Okay, I think that there's ways around that. I mean, we can say we don't feel the ovaries well. We can say somebody has a little bit of pain. There are ways that if someone is really, really concerned, we can generally get it covered. Okay, not always, but generally. If someone has no symptoms and they're really thin and you can feel their ovaries and they just want to have an ultrasound, I mean, insurance isn't going to cover that. They always need to have a reason.
So they're not going to use that as a diagnostic
And it's
Not as a screening tool?
Not as a screening tool. Not as a screening tool because it's expensive. And in the end, when they've done these, and they've done big studies, they haven't shown that looking at ultrasounds and checking C125 improve the survival rate for people who get ovarian cancer. You might pick it up a little bit earlier, but ultimately in looking at large groups of people, when they did these screenings, it didn't improve the survival for the people who had it.
And this is actually true for routine imaging in breast cancer patients too. We don't routinely do CT scans, PET scans, unless you're following the disease for a metastatic setting because they actually showed that there was no change in survival. There was, in fact, higher anxiety in the women who had it, and there was no survival benefit. So we don't routinely do imaging as part of our surveillance for breast cancer.
Any other questions? One more question? Okay, and then I'll do the door prizes.
As far as breast reconstruction, some of us with lumpectomies and then mammocytes or radiation have some pretty funky looking breasts. And I'm just wondering what the protocol as far as any reconstruction or making your two breasts match again. Does insurance cover any of that?
We should have had an insurance person here tonight. Does anybody want to talk about how we go about finding out about reconstruction?
So a couple basic things. So, there's laws for this to help us. So, plastic surgery, reconstruction, nips and tucks on your breast, they're going to be covered one side, both sides for the rest of your life. You need to have care with a plastic surgeon, though. This is care that we don't offer, but we know those who do, and we refer to our plastic surgeons. Lumpectomy site reconstruction after radiation can be difficult because that tissue is forever changed, and often the radiation has been very focused at that lumpectomy site. Sometimes to fill in defects for, mastectomy patients who've had reconstruction will do something called fat grafting, where liposuction is used to harvest fat and inject it in areas that look too flat. But we don't generally do this at the lumpectomy site because it can make the surveillance in the future more difficult, and it's hard to know if the cancer is recurring there or not. Sometimes what they'll do is rotation of a tissue flap, like moving some tissue, muscle, skin from the back into the defect. That can be done. Sometimes implants can be done. So, a patient may have whole breast radiation and then notice that that breast over time has gotten smaller than the other side. So you can, either reduce the contralateral side so you're more equal or put an implant in. I mean, there's all sorts of things that can be done. It's never perfect, but it's something to talk with your surgeon and a plastic surgeon about if you think it could be something for you.
I understand that in the past that radiation has caused some damage to the heart.
breast cancer radiation. I wonder if that's true or if it's now not so true.
So it is both. So we do have a knowledge that radiation to a heart can cause significant side effects later in this woman's life. So that's why we, as of now, doing our best to minimize that radiation that goes through it. And we are quite successful with our modern techniques in treatment planning and delivery to do that in majority of patients in whom risk for radiation-caused cardiac toxicity is minimal these days.
So is it fair to say that as technology has improved, you're able to focus in more on the area where you're trying to either provide the chemo to or provide the radiation to and decrease some of the risk?
It's both technology and the knowledge, being aware. And so the studies that showed cardiac toxicity is meaningful when radiation was used sparingly through the heart and with all the techniques perhaps, and also with the lack of knowledge years ago. Now we have a knowledge
that some of it's dangerous.
We should be
yes.
careful.
We should be
Yeah,
careful.
while trying to help, but also keep the balance.
Yes. As it relates to chemo-related risk factors for developing coronary disease, obviously, unfortunately, we can't mitigate a lot of that risk with technology because it's going through your bloodstream. But what it has become more, there's a lot of education and primary care physicians who are much more aware and cognizant of the fact that they need to do a better job of controlling the patient's blood pressure and other risk factors when they've had chemo. And there's no doubt that having been through chemotherapy, you are at higher risk for coronary disease.
Okay.
What's the difference between radiation with a pill or the machines?
Did you hear? The question is, what's the difference between taking a radiation pill or taking the machine?
There is no radiation pill for the breast cancer.
There's no pill.
There's no pill.
Just a chemo? Just a chemo pill?
Yeah, chemotherapy can be in the pill form or it can be anti-estrogen therapy rather than being in the pill form.
So most chemotherapy drugs, which we call cytotoxic drugs, the drugs that we use for aggressive breast cancer, most of them are intravenous. There are a few that can come in oral form that are converted by delivery to an IV, but majority. So when you talk about pills, it's usually we're talking about anti-estrogen treatments.
Do we have any closing words that anyone on the panel would like to share? Dr. Singh, I think
the one important thing is to be aware of ourselves and to be aware about the family history, because sometimes we know that my cousin had something, my grandmother had something, and then we just think it may be not relevant, but you know what, it can be relevant. The history of ovarian cancer in a family, it's important. It's very relevant. It doesn't have to be more than one person having had ovarian cancer. One person in the family has ovarian cancer, you should get the genetic testing. And if it is positive, then there are ways to handle that situation. But it is important to be aware and to have the knowledge of the family history of breast cancer. Or means the cancer. It doesn't have to be breast. It's the ovarian cancer, the breast cancer, in male, like the male breast cancer, the pancreatic cancer, the prostate cancer, and that knowledge is very important.
we didn't discuss that tonight because this is a women's event, but there are men that suffer from breast cancer too, and I'm sure you treat them in your practice.
Unfortunately, we've seen a little bit of an increase and that's linked to obesity.
It is linked to obesity.
Yeah, but stage for stage, male breast cancer patients seem to do as well, except for the fact that they get diagnosed later because of the lack of awareness, and that's been a major issue. In fact, the majority of 98% of breast cancers, male breast cancers, are estrogen-driven breast cancers, whereas only 70% of female breast cancers are estrogen-driven breast cancers. So that tells you that they're usually the outcomes are good if you find them. But going back to Dr. Singh's, any male breast cancer patient is automatically eligible for genetic testing. So if you have a family member that you're aware of, then that should send up, there should be a red signal, right flag.
Because the women in that family are going to be at very increased risk.
Okay.
As well as the males.
As well as the males.
Yes.
So we have, I don't want to forget to do this. It was very important. They handed it to me early on, but I made you wait. The Peaceful Remedies gift basket goes to Anna Phillips, and the Oswego Health basket goes to Barbara Schnell. Can we have a big round of applause? Besides a round of applause for the vendors, could we have a big round of applause for our panel here tonight? We want to thank you for coming out. We had good Oswego weather for you. There was no snow, and it was 80 and sunny, and it's like that every day here in Oswego, right? Well, thank you very much. I think there's still some refreshments, and don't forget to pick up your goodie bag on the way out, and thank you very much.